Welcome to the deep dive. Today, we're really getting into a core challenge for vascular surgeons, managing abdominal aortic and iliac aneurysms, AAAs and IAAs.
Exactly.
Think of this as, well, a focused guide. We're pulling directly from Rutherford's Vascular Surgery, chapter 71 through 77, basically the whole section on abdominal aortic and iliac aneurysms.
hmm
Our goal here is to sort of distill the really crucial stuff you need for, effective practice today, because this field keeps changing.
It really does. And we'll trace how things have evolved, look at the key definitions, how we diagnose these, and then importantly, the sort of nuances between open and endovascular repair. It's about boiling down these chapters into practical insights.
Okay, good. So let's start maybe with a bit of history. The sources talk about quite a journey, right? Early days were, well, pretty limited for aortic aneurysms.
Oh, absolutely. I mean, you had pioneers like Matas doing amazing work on other aneurysms like ligation, preserving collaterals.
Yeah.
But the aorta itself, that was a different beast entirely.
He did manage the first successful ligation, though.
He did, yes. But for a long time, direct repair was just daunting. A lot of caution.
Right. Then the mid-20th century hits, and things really shift. Duboast in 51, that first successful graft replacement using a homograft, that sounds like a massive moment.
It was huge. A watershed moment, definitely. And then the synthetic grafts started coming along. You know, those early Vignon grafts, initially meant for parachutes, apparently?
No way, parachutes.
Yeah, necessity is the mother of invention, right? Having those materials, then refined by DeBakey with polyester, that really opened the floodgates for durable open repair.
And outcomes started getting much better.
Dramatically better, especially by the 90s. In experienced hands, mortality for elective open repair really dropped.
So open repair became the standard, but then the endovascular revolution happened. Parodi, EVAR, early 90s.
Exactly. Parodi's work was groundbreaking. The first devices got approved in the U.S. in '99.
And now, EVAR is the main player.
For a lot of infrarenal AAAs, yes. It accounts for the majority of treatments. It's less invasive, clearly.
But it hasn't made open repair disappear.
Not at all. Not even close. EVAR has been transformative, no question. But open surgical repair, it's absolutely vital. It's your go-to for certain anatomical challenges, maybe younger patients, some connective tissue disorders, and it's the essential backup if EVAR isn't suitable or, if it fails down the line.
Okay, that makes sense. So you need both tools. Let's dig into the specifics then. Chapter 71 in Rutherford's starts with definitions. What's the core definition of an aneurysm we need to work with?
Okay, so the SVS definition is pretty clear. It's a permanent, localized dilation of an artery where the diameter is at least 50% greater than the expected normal size for that specific artery.
And normal isn't just one size fits all for the aorta, is it?
Definitely not. It varies quite a bit. Population studies like that Swedish MRI study in 70-year-olds give us good benchmarks. So infrarenally, normal is maybe 2.4 centimeters in men, 2.2 centimeters in women, roughly.
So the common 3.0 centimeter cutoff for an infrarenal AAA is sort of a general guide?
It's a useful threshold, yeah. But you have to be more nuanced for, say, the ascending aorta or descending or supraceliac. The normal diameters are different there, and they're gender-specific too.
Why is that nuance so important?
Well, if you just stick rigidly to 3.0 centimeters everywhere, you might miss aneurysms in women, for instance, or maybe overtreat some men in different segments. It really underlines why you need to consider the individual patient, their specific anatomy.
Got it. And it's not just the aorta, right? Other aneurysms often kind of tag along.
That's a really important point. Iliac, popliteal, femoral aneurysms, they're the most common peripheral ones, and you see them quite often alongside AAAs. Always something to look for during your workup.
Chapter 71 also talks about true versus false aneurysms. What's the practical difference there?
So a true aneurysm involves all three layers of the artery wall dilating. A false aneurysm, or pseudoaneurysm, is different. It's basically a contained rupture, the wall is breached, but the bleeding is sealed off by surrounding tissues or thrombus.
And that matters for treatment.
It can, yeah. Peripheral pseudoaneurysms are often iatrogenic, after a procedure. Because they sometimes have this narrow neck connecting them to the artery, you might be able to treat them with things like thrombin injection to make them clot off. Recognizing that difference helps guide your intervention.
Okay. And the shapes? Fusiform versus saccular?
Right. Fusiform is that more general, sort of spindle-shaped widening. Saccular is more like a distinct outhouching, a bubble on the side.
Does the shape tell you anything important?
It can. A saccular aneurysm, especially if it looks inflamed or unusual on imaging, that should be a red flag. You need to strongly consider an infectious cause, a mycotic aneurysm, which completely changes your management plan. Different antibiotics, maybe different surgical approach.
Rutherford's also mentioned some other less common types.
Yeah, briefly. Traumatic aneurysms, often pseudoaneurysms from injury. Some developmental things like persistent sciatic artery aneurysms, and importantly, the genetic link. Even without a diagnosed syndrome like Marfan's, having a family history, especially a male sibling within AAA, significantly bumps up the risk. You always need to ask about family history.
And thoracoabdominal aneurysms.
Less common than infrarenal, but definitely more complex challenges because they involve the visceral arteries.
Okay, so understanding these classifications is really the foundation. Chapter 72 then gets into epidemiology and the pathophysiology, the why. They've been known for ages, apparently.
Oh, yeah. There's evidence suggesting the ancient Egyptians knew about them. Antilles tried ligation way back when, didn't work out so well, but it shows this isn't a new problem. We've just gotten much better at dealing with it.
How common are AAAs now?
Well, about 30% of all aneurysms are infrarenal aortic, and prevalence is tightly linked to age, sex, and race. Age is the big one. Risk really climbs after 65. It's more common in men and in Caucasians. Screening studies really help pin down these demographics.
Which directly influences who we screen.
Exactly. And we often see iliac artery aneurysms, IAAs, with AAAs too.
Right. How common are those?
Pretty common, mostly in the common iliac artery. They occur in a fair percentage of AAA patients.
Yep.
The definition is usually diameter 1.5 times normal. So generally over 1.85 centimeters in men, 1.5 centimeters in women. Isolated internal iliacs are pretty unusual, though.
Okay. Let's get down to the cellular level. What's actually happening in the aortic wall? What's the pathophysiology we need to grasp?
The core issue is a breakdown in the aortic media, that middle layer. You get destruction of elastin fibers and loss of smooth muscle cells. Inflammation is a major player. Lots of inflammatory cells infiltrate the wall. You also see neovascularization, new leaky blood cells growing in, and abnormal collagen deposition. It's a complex degenerative process.
And that clot inside, the interluminal thrombus, or ILT, you'd think it might protect the wall, but maybe not.
It's kind of counterintuitive, isn't it? But the evidence suggests the ILT actually contributes to the wall weakening. It seems to activate platelets, increase oxidative stress right near the wall, and it's a source of proteolytic enzymes, especially matrix metalloproteinases, MMPs.
MMPs, like MMP9.
Exactly, MMP9, MMP2, MMP12. These enzymes chew up the structural proteins like elastin and collagen. And studies suggest a thicker thrombus is linked to faster aneurysm growth, maybe partly by blocking oxygen diffusion to the wall.
Which explains why researchers looked at MMP inhibitors.
Precisely. It seemed like a logical target, but unfortunately clinical trials in humans haven't shown a clear benefit in slowing AAA growth.
And genetics, we mentioned family history.
It's huge. Heritability is estimated around 70%. If your patient has a first-degree relative within AAA, their risk is roughly doubled. We're starting to identify specific gene locations linked to AAA risk through large genetic studies. Maybe someday that'll help with risk prediction.
And then there are the specific connective tissue disorders.
Right. Things like Marfan, Loeys-Dietz, vascular Ehlers-Danlos. These are known causes of familial aneurysms, each with a specific genetic defect affecting structural proteins or signaling pathways. Recognizing these is critical because it impacts surveillance, treatment choices, and counseling for the family.
Okay, let's shift to Chapter 72's coverage of diagnosis and medical therapy. How do these patients typically present? Or do they?
Most don't, actually. The vast majority are asymptomatic. They get picked up incidentally on imaging done for something else entirely.
So finding it is often accidental.
Often, yes. If they do have symptoms, it's usually pretty vague, maybe some nonspecific abdominal pain or back pain. In a really thin person, you might feel a pulsatile mass on exam, but you can't rely on that. Key risk factors, smoking history, hypertension, atherosclerosis, should raise your index of suspicion.
So imaging becomes absolutely key. What are our main tools?
Ultrasound is great for screening. It's accessible, no radiation. But for detailed planning and assessment, CT, specifically CT angiography or CTA, is the workhorse.
What does CTA give you?
Excellent anatomical detail. You see the calcification, the thrombus burden, any associated occlusive disease. And the multiplanar and 3D reconstructions are essential for planning either open or endovascular repair, measuring lengths, diameters, angles,
Downsides to CT.
radiation exposure, of course. And the contrast dye can be an issue for patients with significant kidney disease.
So what's the alternative then?
Magnetic resonance angiography, MRA. It's a good option for patients with a renal insufficiency, as you can often avoid iodinated contrast. Gives good detail, too.
All right. And screening. who should we be screening for AAAs based on current guidelines?
The guidelines have evolved. Generally, the recommendation from most societies, like the SVS, is a one-time ultrasound screen for men aged 65 to 75 who have ever smoked.
What about women? That's been more debated.
It has. But the thinking has shifted. We now know that women who smoke and develop AAAs tend to have a higher rupture risk at smaller sizes. So screening women aged 65 to 75 with a smoking history is also generally recommended now by groups like SVS and ESVS.
Any refinements on the horizon for screening?
There's interest in the aortic size index, basically, adjusting the aortic diameter for the patient's body size. That might help refine risk, especially in women, but it's not standard practice yet.
And if you find a small aneurysm on screening,
Then it's about surveillance. The interval between follow-up ultrasounds depends on the initial size. Smaller ones get watched less frequently than larger ones approaching the threshold for repair.
okay. What about medical therapy? If you have a small AAA, can you do anything besides watch it?
The mainstays are aggressive risk factor modification. Number one is smoking cessation, absolutely critical, and tight blood pressure control. These are the only things with decent evidence suggesting they might slow growth or reduce rupture risk.
What about things like statins or beta blockers? Lots of research there.
A ton of research, yes,
Mm-hmm.
both preclinically and clinically. But unfortunately, large human trials haven't shown a definitive benefit for statins, ACE inhibitors, beta blockers, or even certain antibiotics in terms of slowing down AAA progression in humans.
So no magic pill yet.
Not yet. Moderate exercise seems to be safe and well tolerated, though. It doesn't appear to increase growth or rupture risk, but yet currently no specific drug reliably halts or reverses AAA growth.
All right, let's move into Chapter 73. Indications and planning for open aortic repair. We know rupture is bad news, high mortality. How does elective open repair compare?
The difference is night and day. Ruptured AAA mortality is still tragically high, maybe 40–70% overall. But elective open aortic repair, done in experienced centers, the mortality is much, much lower, often around 3%, sometimes even less. It really underscores why screening and timely repair are so important.
And this is where the balance between open and endo comes in again.
Absolutely. EVAR took over for a lot of straightforward infrarenal AAAs, which has actually led to some concerns about maintaining proficiency in open repair.
So training is an issue.
It's something we need to be mindful of. Ensuring surgeons get adequate open experience, maybe through dedicated fellowships or concentrated complex open cases in higher volume centers, is important for maintaining good outcomes.
Okay, so when would you choose open repair today? What are the main indications according to Rutherford's?
Box 73.1 lays it out pretty well. Key reasons include anatomy that's just not suitable for EVAR, maybe a really short or angulated neck, severe iliac disease, a hostile abdomen from lots of prior surgeries could make EVAR tricky.
What else?
Younger patients, generally. They have a longer life expectancy, and the long-term durability of open repair is very well established. Also, patients with certain connective tissue disorders or genetic syndromes. Infected aneurysms, what we call mycotic AAAs, or inflammatory AAAs, often require open surgery.
And aortoenteric fistula.
Definitely an indication for open repair. Also, if you need to do another open procedure at the same time, and of course if EVAR has failed and you need to do an open conversion.
So once you've decided on open repair, the planning phase is crucial.
Absolutely. Meticulous planning is needed. High-quality CTA is your best friend here.
What are you looking for specifically on that CTA?
Everything. The aneurysm's geometry length, diameter, angles, tortuosity, the extent of calcification and thrombus. Importantly, the quality of the aorta where you plan to put your clamps, especially the proximal neck.
You need a good spot to clamp.
You really do.
Yeah.
You also need to carefully evaluate the visceral segment. The renal arteries, the SMA, the celiac, are they involved? What's their status? And look for any anatomical variants. Like a retroaortic or circumaortic left renal vein. You don't want to injure that.
Yeah.
Multiple renal arteries are common. Horseshoe kidney needs special consideration. And assess the distal vessels, iliacs, femorals, for any occlusive or aneurysmal disease that might affect your distal reconstruction.
What if CTA is out? Kidney problems again.
MRA is a reasonable alternative then. Gives you good anatomical information.
Okay, planning done. What about the actual surgical approaches for open repair?
Primarily two options, transperitoneal or retroperitoneal.
Transperitoneal, that's the standard midline laparotomy.
Exactly. Midline incision goes straight in. It offers rapid access. Most surgeons are very comfortable with it. The downside is potentially more bowel manipulation, which can lead to ileus or maybe more pulmonary issues post-op.
And the alternative, retroperitoneal.
That's usually a left flank incision, maybe 11th or 10th interspace. You stay behind the peritoneum, moving the kidney forward.
Advantages?
Less bowel handling, potentially better access to the paravisceral aorta, maybe even supraceliac. And some recent studies suggest maybe lower rates of late reintervention or readmission compared to the transabdominal route, though that's still being debated.
So the choice depends on the situation.
Yeah, surgeon preference, patient factors like previous surgeries, and the specific anatomy, especially how high the aneurysm goes, all play a role.
Can you walk us through the transperitoneal approach briefly? Key steps.
Sure. Midline incision, retract the bowel, usually to the right. Divide the ligament of Treitz to mobilize the duodenum off the aorta. Careful dissection down to expose the infrarenal aorta and the iliacs as needed.
What if the iliacs are really calcified for clamping?
That can be tricky. Sometimes placing external clamps can fracture plaque. In those cases, you might consider using internal balloon occlusion, like with a Fogarty or Foley catheter, inserted through the arteriotomy.
And getting higher proximal exposure if needed.
You might need to mobilize the left renal vein. Sometimes you can retract it. Other times it might need to be divided. You have to be sure there's adequate collateral drainage, usually through the gonadal and adrenal veins. And always watch out for that retroaortic vein variant.
Okay. Now, the retroperitoneal approach, how does that work?
Left flank incision, as I said. You divide the muscles of the abdominal wall, enter the retroperitoneal space, and carefully retract the peritoneum and its contents medially. You usually develop the plane behind the kidney, the retrorenal plane.
What do you need to watch out for there?
The left ureter is key. Identify it early and protect it. This approach gives really nice exposure up to the visceral segment and even the supraceliac aorta if needed.
All right, aorta exposed. How do you reconstruct it?
Okay, first, systemic heparin. Then clamps go on, usually distal clamps first, then the proximal clamp. Open the aneurysm sac longitudinally, maybe a T incision. Clear out all the thrombus and any loose debris or calcium.
Then the sewing starts.
Right. Proximal anastomosis first, usually with a running polypropylene suture. Make sure it's secure and hemostatic. Then deal with back bleeding lumbar arteries inside the sac. Ligate them with sutures.
Then the distal part.
You tailor your graft, either a straight tube graft at the iliacs are okay, or more commonly a bifurcated graft. So the distal anastomosis, or anastomosis for a bifurcated graft. Before you tie the last suture, you flush the graft forward from the proximal clamp and allow back bleeding from the distal vessels to clear any air or debris.
And closing up.
Restore flow. Check for hemostasis. Then typically you close the native aneurysm wall over the graft with an absorbable suture. Helps reduce dead space. In the transperitoneal approach, you close the posterior peritoneum over that. Maybe bring down an omental flap for extra coverage if needed. Then close the abdominal wall.
What about those higher aneurysms, pararenal or suprarenal, done retroperitoneally? How do you handle the visceral arteries?
That's where it gets more complex. You might need techniques like creating an inclusion patch, incorporating the renal artery origins into the anastomosis, or using prefabricated branched grafts, or even hybrid procedures. The key is minimizing the ischemia time to the kidneys and intestines.
Renal protection strategies.
Definitely, especially if you need suprarenal clamping. Cold crystalloid perfusion into the renal arteries during the clamp time can help protect kidney function. Careful fluid management is also critical.
And other things to consider, like the IMA.
Good point. The inferior mesenteric artery. You need to assess its importance before ligating it. If it's large and collateral flow seems poor, you might need to reimplant it into the graft. And always be aware of variant renal anatomy, like horseshoe kidneys, which require specific handling.
Okay, surgery's done. What's the focus in postoperative management?
These patients almost always go to the ICU initially. Close monitoring is key. Pain control is important. Epidurals can be very effective if used. Respiratory care is big too. Aim for early extubation, but watch for complications like pneumonia.
And kidneys. You mentioned AKI risk.
Yes, acute kidney injury is a major concern, especially with higher clamp levels or prolonged clamp times. Risk increases significantly with suprarenal clamping. Careful monitoring of urine output and creatinine is essential. Some patients might even need temporary dialysis.
How about long-term follow-up after open repair?
Standard practice, based on SVS guidelines, is usually a baseline CTA around 6 months post-op, and then surveillance imaging, often CTA again, maybe every 5 years or so.
Yeah.
Just to make sure everything looks good, no late pseudoaneurysms or issues. And consider checking the chest, too, for metachronous thoracic aneurysms.
What about tackling complications like converting a failed EVAR?
Open conversion after EVAR can be challenging. There's often a lot of inflammation and scarring around the old endograft. Getting proximal control above the graft, especially if it has suprarenal fixation, can be tough. You have to decide whether to remove the old endograft components or incorporate them. It requires careful planning.
And infected aneurysms, MAAs.
That's a really serious situation. Diagnosis relies on clinical suspicion plus CTA findings like periodic inflammation, gas, or fluid. Treatment usually involves extensive debridement, surgical repair, and long-term antibiotics. The type of repair is debated in situ reconstruction with a prosthetic graft soaked in antibiotics, or sometimes using autogenous tissue like femoral vein, neo-aortoiliac system, or NANIS, or even extra anatomic bypass in some cases. EVAR might sometimes be used as a bridge to definitive treatment in unstable patients.
And inflammatory AAAs, IAAs.
Those have that characteristic thick, fibrotic peel around the aorta, often encasing the duodenum or ureters. Surgery is tricky. Minimal dissection is key. The retroperitoneal approach is often preferred to avoid mobilizing the stuck duodenum. Proximal control can be difficult, often needing suprarenal clamping. The aortic wall itself can be fragile. Ureteral stents are often placed beforehand. Mortality rates are higher than for standard AAAs.
Okay, that's a lot on open repair. Let's switch gears to Chapter 74, endovascular techniques. Lots of different EVAR devices out there now.
Oh yeah, a whole range of commercially available infrarenal endograft systems. They differ in how they achieve fixation hooks, barbs, radial force, how they seal against the aortic neck, the materials, the limb designs, the delivery system size.
What are the key characteristics you look for in a device?
Radiopacity is important. You need to see it well under fluoro. Deployment accuracy and control. Ease of use, familiarity with the system, and the profile of the delivery sheath smaller is generally better for access.
How do you pick the right one?
It really comes down to the patient's specific anatomy. The length, diameter, and angle of the aortic neck are critical. Also, the iliac artery anatomy diameter, tortuosity, calcification. Some devices are better for short necks, others handle angulation better. You choose the device that best fits the anatomy you're dealing with.
Most are bifurcated grafts, right?
Yes, the vast majority for standard AAA repair are bifurcated, either modular designs where you connect the limbs, or less commonly unibody designs. Aorto-uni-iliac devices where you graft to one iliac and block the other, then do a fem-fem bypass, are reserved for specific situations.
And if the neck is too short for a standard infrarenal device,
Then you're into more complex EVAR territory, using fenestrated grafts, FEVAR, with holes for the renal arteries, branched grafts, BVAR, or sometimes parallel graft techniques like chimneys or snorkels, TVAR. That's a whole advanced topic itself.
planning for EVAR sounds absolutely critical.
It is, probably even more so than for open repair in some ways. Precise preoperative sizing and meticulous planning are everything for a successful EVAR outcome.
And CTA is the key again.
Absolutely. Thin slice CTA, 2.5 millimeter slices or less, is the cornerstone. You need to carefully review the axial images, but also the coronal, sagittal, and especially the 3D reconstructions.
Centerline analysis.
Yes, specialized software that calculates the true centerline path of the aorta and iliacs. It allows for very accurate length and diameter measurements, accounting for tortuosity, which is crucial for choosing the right graft size and length. Angulation measurements are also critical.
What if contrast is a major issue? Renal failure.
There are alternatives.
Yeah.
Intravascular ultrasound, or IVUS, can be used during the procedure to measure diameters directly from inside the vessel. CO2 can be used as a contrast agent instead of iodinated dye, or sometimes a very small amount of contrast injected directly into the aorta via a catheter.
Okay, planning's done, device chosen. What happens in the OR during a standard aorta?
Typically starts with accessing the femoral arteries, usually percutaneously now, but sometimes with open cut-downs. Guide wires are passed up into the aorta.
Then the main device goes in.
Right. The main body delivery system is introduced usually over a stiff wire. It's positioned precisely under fluoroscopic guidance, using bony landmarks and often a pigtail catheter in the aorta for reference or contrast injection. The graft is then deployed, paying close attention to the proximal landing zone just below the lowest renal artery.
Then the other side?
Correct. You then gain access from the contralateral femoral artery, cannulate the gate on the main body of the endograft, and deploy the contralateral iliac limb. Sometimes, especially with shorter main body devices, you might need to gently cross the limbs within the aortic sac, a technique sometimes called ballet, to get the contralateral limbs seated properly.
Then balloons.
Yes. Once the main body and limbs are deployed, you typically use compliant balloons to mold the proximal neck and the distal iliac landing zones. This helps ensure a good seal against the vessel wall. You have to be careful not to be too aggressive with ballooning, though, especially in calcified necks.
In fact,
Completion angiography. Inject contrast to confirm the graft is fully expanded, all limbs are patent, There's good flow down to the legs. And most importantly, to check for any endoleaks.
Endoleaks. Leaks back into the sac.
Exactly. There are different types defined by where the leak originates. Type I is a leak at the proximal IA, or distal IB, attachment site, a seal failure. Type 2 comes from collateral vessels like lumbar or IMA feeding back into the sac. Type 3 is a defect in the graft fabric or between components. Type 4 is graft porosity, rare now. Type V is endotension, sac expansion without a visible leak. Recognizing these is crucial for follow-up and potential reintervention.
Okay. Chapter 75 is explicitly detailed here, but presumably it builds on this, focusing specifically on aortoiliac aneurysms.
Right. It would likely delve into the specific EVAR strategies when the aneurysm involves both the aorta and the iliac arteries. That means discussing things like using longer iliac limb extensions, maybe using flared iliac limbs for larger common iliacs, but also the limitations of flared limbs, especially for very large diameters where the risk of a type E endoleak increases.
And preserving pelvic flow becomes really important then.
Absolutely critical. So, Chapter 75 would almost certainly cover techniques for dealing with the internal iliac artery. This is where iliac branch devices, or IBDs, come in. These specialized endografts have a side branch designed to stent into the internal iliac, preserving flow to the pelvis.
Compared to just covering or embolizing the internal iliac.
Exactly. Covering or coiling off the internal iliac was common practice, but we now know that bilateral occlusion leads to significant risk of buttock claudication, erectile dysfunction, and sometimes even colonic ischemia or paralysis. IBDs offer a way to treat the common iliac aneurysm while keeping that crucial internal iliac flow going. Managing the aortic bifurcation and ensuring good landing zones both proximally and distally are also key points for aortoiliac EVAR.
Makes sense. Now, Chapter 76 tackles ruptured AAAs, a really high-stakes situation. Mortality is still high.
Still distressingly high, yes. 40 to 70% overall mortality remains the grim reality, although some recent trends suggest maybe slightly better outcomes, possibly due to more screening catching aneurysms earlier, and perhaps the increased use of an EVAR for strategy in suitable patients, even in rupture.
Why might EVAR be better in rupture if the anatomy fits?
The thinking is it avoids the major physiologic insult of laparotomy and aortic clamping in an already unstable patient. Less blood loss, potentially less fluid shifts, avoidance of gut manipulation, maybe lower risk of complications like MI, renal failure, colon ischemia that come from the ischemia reperfusion injury associated with open clamping.
So the immediate management. Suspected RAA.
It's an emergency. ABCs, airway, breathing, circulation, rapid diagnosis, often clinical suspicion is enough in an unstable patient with known AAA or risk factors, maybe a quick bedside ultrasound. CT only if stable enough and the diagnosis is truly unclear. Then immediate transfer to a center capable of handling it, ideally with vascular surgery available 210-4/7.
Permissive hypotension.
Yes. During transfer, the idea is to keep the blood pressure just high enough for vital organ perfusion, but not so high that you worsen the bleeding before surgical control is achieved. Target may be a systolic of 70-90 millimilli Hg.
And in the OR, open versus endo for rupture.
If the patient's anatomy is suitable for EVAR and the team is experienced, EVAR is often preferred now. REVAR ruptured EVAR. It might involve using an aortic occlusion balloon inserted from the arm or groin to get proximal control quickly while the endograft is prepared and deployed. If EVAR isn't feasible due to anatomy or instability, then it's open repair, focusing on rapid proximal control, often supraceliac clamping initially, then repairing the aorta.
Specific challenges in ruptured cases.
Oh, many. Coagulopathy is common due to blood loss and consumption of factors. Hypothermia is a killer and need aggressive warming measures. Abdominal compartment syndrome is a real risk after massive resuscitation or retroperitoneal hematoma. You might need to leave the abdomen open temporarily with a VAC dressing. And all the systemic complications, cardiac events, kidney failure, lung injury, ARDS, bowel ischemia are much more frequent after rupture.
Does center experience matter?
Hugely. High-volume centers generally have better outcomes for RAAA for both open and endovascular repair.
Okay, lastly, Chapter 77 zeroes in on iliac artery aneurysms specifically. They have their own issues.
They do. Common iliac aneurysms, IAAs, can be complex, fusiform, or kinked, and they have a high tendency to rupture, often at smaller diameters than AAAs. Elective repair is usually recommended around 3 to 3.5 centimeters, maybe even smaller if symptomatic. Internal iliac aneurysms, IAAs, are rarer, but rupture at larger sizes. Even external iliacs, EIAAs, 4 centimeters, have a significant rupture risk.
So repair threshold is lower than for AAAs.
Generally, yes. And surveillance is important too, watching smaller ones, and also long-term follow-up after repair, because aneurysm disease is systemic, Need to watch the rest of the aorta and the other iliac.
We talked about IBDs for aortoiliac aneurysms. Are they the standard now for isolated CIAAs needing repair too?
Increasingly, yes, especially if you want to preserve internal iliac flow. If an IBD isn't feasible, other options include coil embolization of the internal iliac, followed by stenting across its origin with the main iliac limb extension, or sometimes surgical bypass. But preserving at least one internal iliac artery, preferably both, is the strong recommendation from guidelines.
Why is preserving the II so important?
Pelvic perfusion. Bilateral IIA occlusion significantly increases risk of buttock claudication, sexual dysfunction, spinal cord ischemia, pelvic necrosis, serious morbidity. So using IBDs or other preservation techniques is really preferred over sacrificing both internal iliacs if at all possible.
So endovascular is generally preferred for iliacs too.
For suitable anatomy, yes. Outcomes seem comparable or potentially better in terms of morbidity compared to open repair for isolated IAAs, according to systematic reviews. Different types of IBDs are available now, like the Cook's EBIS and Gore IBE, with good reported outcomes.
Wow. We've covered a massive amount of detail from these chapters. It really is like an instruction manual. If you had to boil it down, what are the absolute core principles for managing AAAs and IAAs today?
Okay, I'd say 1. Understand the definitions in natural history. 2. Use imaging wisely for diagnosis, surveillance, and meticulous planning. 3. Carefully select patients for open versus endovascular repair based on their anatomy, their overall health, and expected longevity. 4. Execute the chosen procedure with technical precision, whether it's open or endo. 5. Be vigilant about postoperative care and long-term surveillance. And 6. Always prioritize preserving pelvic perfusion when dealing with iliac involvement.
That's a great summary, and obviously for anyone wanting the full detail, diving into Rutherford's itself is essential.
Absolutely. This was a deep dive, but the chapters themselves have even more nuance and detail.
Right. So as we wrap up, maybe a final thought to consider. Looking ahead, with endotech evolving so fast and our understanding of aneurysm biology getting deeper, how do you see treatment changing? Are we heading towards more personalized approaches, maybe effective medical therapies finally, or more complex hybrid repairs becoming routine? Something for you, our listener, to think about. Thank you for joining us for this deep dive.